it's not all rosy, right? Even the best systems. Could you talk about bias, hallucination, transparency, trustworthiness, data security, privacy?
Yeah,
Uh,
absolutely.
yes.
That's like probably one of the most critical conversations we have all the time in, again, as I said, I was pharmaceuticals, biotech. Um, just grounding, as I like to do, is one of the things that I've tried to do in my practice now with Kindly is helping people think about bias very differently and hallucinations from the way it had been positioned in the past. In the past, it almost felt like the models were just inherently and intentionally trying to create bias for certain segments of the community, right? That's reality. And what I found in those scenarios where people were shutting themselves out of an opportunity to really shift the narrative, but actually shift the way these models work. So when I think about hallucinations, AI hallucinations, it's a reality that these models were trained on the vast, data available from the internet, worldwide internet. And even though they have so much information and knowledge, a lot of times, there are many times we ask questions and there are patterns they can't find. So when they can't find those patterns in their large corpus of information, they fill in the gaps. And that's really where the hallucination comes in. I tell people, it's like it takes a look. I take a picture and Dr. Famuyide, I'll be standing next to you, but standing too far apart. And the AI, brain would be like, why are they so far apart? I thought they were supposed to be friends. You know what? I'm going to either fill the gaps with other people who look friendly or I'm going to force them together. We intentionally stood apart for a reason, but it doesn't know that. And so hallucination is just how it tries to fill in the gap to be useful. The bias part is naturally there has been a lot of bias that's been baked historically into the data sets that have been used and unfortunately were used to train these models. And so I say the models are not because they're not human, they're not intentionally biased, but it's the nature of how they were trained. So when I talk about bias in healthcare and how we can mitigate to drive better value. And the one thing I should also add when we talk about low resourced um, communities, most of the data that we have in these LLM models were trained on Western data, English too. So I think that's also very important. So I just got back from Ghana. The onus is on us to really start collecting our data and creating the cleanest as possible, the cleanest data, so that these models we can leverage the advanced, I would say the advanced logic that it uses for pattern recognition, but really anchored to understanding us because that's part of the challenge as well. But I would say, we should be asking questions, before the model is built when we talk about bias, because bias is actually where a lot of the biggest impact is in terms of care of patients. How is the model built? So before it's built, the curation, who is represented in the training data set for the model. Sometimes you know, sometimes you don't, and that's why what Eva said was really resonated. You know the data that you're feeding into your models. Who is missing? Really important. We as leaders, we as clinicians should be asking those questions. Are there patients who traditionally get left out that are left out again, and why? And do I have data that I can also inject to make sure they are not left out? During the development, making sure that, we are actually testing, like we basically we have the disaggregated testing across the different demographic areas. I talk about this a lot. It should be mandatory. We don't want a model to actually conflate performance from one demographic and apply that in a blanket fashion across others. So that is really important. After deployment, usually, and I think about what even happened in our pharmaceutical world where we're working closely with hospital systems and get very excited by this pilot, a lot of times is we tend to just celebrate a quick success without asking the core questions around, again, um, what biases exist for the different demographics, what biases exist for geographically. And, for the US, there are biases that could be applied based on your zip code, even without talking about race. So those are the kinds of things that we should always be looking at. How do you stratify your outputs by age, by gender, by social economic status, geography, and make sure that it's built in to your process. And last but not least, I would add that it's really important that the most senior people in the room are are trained to understand to ask these questions. I know in the world we live in right now, bias feels like it's tied to DE and I, and um, but it's just inclusion is good business for everybody. And so taking away that conversation around bias and decoupling it from DE and I for a second and really thinking about what it means for greater healthcare outcomes, better revenues for the hospital systems, better revenues for pharmaceuticals and corporations actually would make the AI bias conversation easier. I think I went in many different directions, but hopefully I answered the question.
You did very, very comprehensively. Thank you. So
Thank you.
I'm going to give the last word to Yoko, right, to sort of look at the pitfalls, for countries at country sort of systems scale. What would you see as common pitfalls, the countries or institutions encounter when they try to either adopt AI in healthcare or they want to scale AI in healthcare, and how can they avoid it?
Yes. I think, I mean, I can go on so many tangents, but I think Ms. Salami mentioned a lot of these points already. And of course, Eva, um, the pitfalls is, of course, is what everyone already mentioned, is to be too excited about the concept of AI and applying AI like a bandage, where before understanding what the true problems within the healthcare workflow lies or in your clinical practice, whether it be, you know, like a health resource, health personal resource, scarce resource, or workflow problems due to like paper-based systems. For example, I studied health insurance systems in Ghana and Rwanda, and I'm doing a comparative study of digitizing these claim management systems. There, it is not directly tied to clinical practice, but it does have impact on the clinical practice in a way that the reimbursement, if they are delayed, it directly impacts the cash flow at the facility level. Then that impacts the clinical service provision, procurement, paying the staff, and so it's sort of a whole chain reaction. So when you think about digitizing or applying AI anywhere, back office functions such as claims management or human resource management in healthcare settings, those places you already probably are collecting data or there is a larger data set existing already, like the payment or the personnel management, before you can think of solving issues like an ambience, scribing, and that sort of thing in the resource limited settings, but maybe focus more on the healthcare management in the back office sense, before jumping onto like more sexy sort of like healthcare provision application in those areas. So before you apply AI, you want to apply AI, you want to think about, do we have the infrastructure to collect data? Do we have our own data? If not, what are the implications of importing data sets from abroad? It's already, I think, talked about by others on this panel. But those things you need to think about, and of course, the pitfalls are without understanding the consequences or the implication of those things, and just applying AI blindly without understanding what that might mean in your own context, then you would see results which you wouldn't understand at the end, and that could have a dire consequence in terms of patient outcomes.
That is so good, Yoko, because, and that's a good place to actually land this discussion. Uh, because if you think about AI, we think of it as something that's only happened in the last 3 or 4 years, when in fact, there's been various forms of AI that people have tried to adopt since the 50s in healthcare. And every attempt, whether it's in the 50s or 70s or even as late as 10, 15 years ago, you remember Watson supercomputer, right? Um, and that was going to be used for diagnosis. They all failed because the initial use cases was the most complex thing they could pick up, which is how to diagnose a condition, right? Instead of starting with the really easy things and the most painful things that you have to deal with, the back office stuff, right? Patient scheduling, patient billing, patient, workflow, those kinds of things. So it's a good place to land this conversation. Again, I want to thank all the panelists, Ms. Salami, Ms. Shimada, and Ms. Eva Amfrans. Thank you for making the time. Dr. Dawudu, I think this concludes our part of the discussion. If you want to take it away.
Thank you so much, Dr. Famide. I know it's really early your time. We appreciate you sort of joining us. So thank you so much. I mean, this has been an amazing conversation. We thank the panelists, Barbara, Ava, and Yoko, for really an amazing conversation. So I'm going to hand over to Dr. Mehari to introduce the next moderator panel. Dr. Mehari, over to you. Thank you so much. This was a wonderful conversation. Hello? Dr. Mehari? Hello, are you there?
Myself, no problem. Hey, goodbye. Hey, everyone. So, in the interest
Okay.
of time, I'm happy to
So,
introduce myself and get the ball rolling.
Yes, so please, Professor Anderson is the
No problem.
moderator for the next session. Thank you so much for moderating this next session.
Okay.
And I'm going to leave it to you, given your time constraint. We're very grateful. He's taking a break from a board meeting to join us. Thank you so much. Over to you.
Thank you. Thank you so much, Igbe. Thank you, Ananda Group, as well as People to People, for organizing this very important topic, very timely topic. I am Wanderson Gabriel. I'm a professor of molecular epidemiology from Ohio State University, and I lead the Global One Health Alliance. I am currently in Nairobi, even though my home base is Columbus, Ohio, at a Board of Trustees meeting at the International Livestock Research Institute. Great to be here, and thank you. Very large group of people interested in this topic. I'm also interested to learn. I'm one of the least knowledgeable of AI. I think I'll be perfect moderator because I can ask many questions easily for my panelists. So I think that's my quick introduction. We have two panelists, supposedly. I know for sure one of the panelists is here, Dr. Wubrest Bakala. And I do not see, at least so far, Professor Salomon Nagash. But in the interest of time, let's go ahead.
I am here. I'm Solomon,
Okay.
and I'm here.
Excellent. Okay, let's start with Dr. Wubrest. Please introduce yourself. And then, Doctor, can you be on video, please? That would be nice to see each other for the conversation, Dr. Solomon.
Unfortunately, no, I won't be able to have video.
Okay. Okay, no problem. Okay, let's start with you, Dr. Wubrest.
Hello, everyone. Good morning. It's an honor to be part of this panel and to learn from the previous panel discussion as well. My name is Dr. Wiblis Bakele. I'm a physician by training, but I have long years of work experience in the global health space, working in biotech research, and also recently I've been involved in working in the AI space, developing regulatory framework on the LLM models whenever they generate health education or responses to users, how they should respond to those questions, and also evaluating the responses. So I